Good afternoon, everyone, and thank you for attending today's session. My name is Mila Stanijic. I am a medical science liaison for the Western Provinces with Sanofi Pasteur, and I have the pleasure of announcing our presenter today, Dr. Dion Neame, and his talk will be titled The Race to a COVID Vaccine. Dion?
Thanks very much, Mila. It's a pleasure to be here. So you're probably wondering, who is this person and why is he talking today? Well, as Mila has announced to you, thank you very much, Mila. I am from Sanofi Canada, and I've got roles in the medical department. But who am I? I'm a physician. I've been a physician since 1991, and I did a residency in internal medicine, then a residency in pediatrics with a fellowship in primary prevention of disease. For the first half of my career, I spent 80% of the time in clinical medicine and about 20% of the time working on vaccines. And in the last half of my career, I've been doing the opposite. I flipped it over. So now I'm doing about 80% vaccine research with Sanofi and vaccine understanding and implementation of different vaccine programs, and about 20% clinical work. So yeah, I guess I understand a lot about infectious diseases and vaccines, vaccine programs, epidemics, pandemics, and I'm here to share that knowledge with you folks today. I would put a little caveat there on race. Race is a concept that does need caveats, and when we're talking about vaccine production, vaccine companies need to go quickly, certainly during these times of crisis, during these times of pandemic, but vaccine companies also have to abide by a strict clinical process to ensure that the vaccines are safe, that they're efficacious, and how effective are they going to be in the community. So is the vaccine company that produces the COVID-19 vaccine first the true winner of the race? Maybe, maybe not. Let's dig a little deeper. So Mila, I'll ask you, if you don't mind, because you're in the driver's seat there, if you could change to the next slide. As a disclaimer slide, much of what I'm talking about today is technically considered off-label because SARS-CoV-2 is a novel virus, and the SARS-CoV-2 candidate vaccines are still being studied and therefore haven't been licensed in Canada at this point. That said, I will be discussing vaccine categories, and I won't be discussing specific vaccines. Next slide, Mila. Today's presentation objectives. Let's go back in history and look at an example of the impact of global infectious disease outbreak. Let's review the chain of infection, discussing British Columbia's response to the first wave of COVID-19, vaccine development, where are we today, general overview of the candidate COVID-19 vaccines in 4 categories, and preparing for the impact of the upcoming respiratory season. The twindemic. This is a neologism that was created by Dr. Tam of the New York Times on August 16th to describe the infectious disease possibility coming to North America in the 4th quarter of 2020, which would be a co-infection of influenza and COVID-19. So we will be looking at the impact of global outbreaks first. So next slide. Great, thanks, Mila. So when people talk about global pandemics, they tend to focus on the last global pandemic, the Spanish flu pandemic of 1918. So what happened in this pandemic? The influenza virus at the time had a dramatic mutation called a shift to a virus that people had never been infected with before, a novel virus, and therefore everyone was susceptible. The Spanish flu is thought to have begun in these cramped and crowded army training camps on the Western Front. But for a pandemic to occur, the novel virus must be transmitted around the world. So in this case, World War I, where soldiers were traveling back and forth across countries, across continents, around the world. And unfortunately, the novel virus was transmitted from person to person via the military. And when the soldiers returned home in around November 1918, they seeded the novel virus into their countries of origin. And the end result was pretty nasty. There's about 50 to 100 million deaths. Next slide. But it's not all bad news. There's good news, and the good news is vaccines. My vaccine colleague, now retired Dr. David Shifley, who resides in British Columbia, he coined the term disappearograms. So if an infectious disease emerges, tried, tested, and true solution is vaccines. Looking at multiple examples here: polio, diphtheria, tetanus, measles, pertussis, tuberculosis are all high infectious diseases. But vaccination programs, you can see with the red arrow, when they're implemented, they result in a dramatic reduction in the disease, the term disappearograms. The infectious diseases are essentially disappearing. So let's jump to 2020. And Milay, next slide, please. So now we have the coronavirus. Now the coronaviruses have been around for a pretty long time, long enough to have become clinically significant and long enough to have its own classification. Now if we go from north to south on this slide, we can see that the family of coronaviruses are known as Coronaviridae. And they have a genus. Now the genus is alpha, beta, gamma, and delta. Now the alpha and beta, those are the ones that we tend to think about because those are the coronaviruses that affect humans. Now there's 7 in the lineages, the ones on the left and then the ones on the right. The ones on the left, those are the kind of really annoying upper respiratory tract infections that occur, can be between 10 to 30% each season, each winter season. Most of the coronaviruses give us a common cold. But on the right side, you have an unusual 3. And those unusual 3, starting with an endemic that occurred in 2002-2003, which was known as SARS. It was an endemic that happened in China, but it did come to the Greater Toronto area due to flights from China to Toronto. I remember it well because I'm from Hamilton, Ontario. And it was quite a time. It was severe acute respiratory syndrome. Unfortunately, I lost a few frontline colleagues during that time. And there's 2012, which was MERS, the Middle East Respiratory Syndrome. And that was an outbreak, obviously, in the Middle East and Saudi Arabia. And of course, today we have our pandemic, our SARS-CoV-2, aka COVID-19, which is occurring now. Next slide, Milay. So coronaviruses are, kind of medium-sized viruses. They are quite simple in regard to their structure. So if you go from the middle, the core, to the outside, in the middle they have their genetic material, their RNA. And then they have a outer caspid. That caspid has many different proteins, but pretty much everybody wants to talk about the spike protein because that's the one that mediates the receptor binding to the respiratory cells or other cells. And then causes infection. Next slide. Thanks, Milay. Okay, so, well, how did we get this SARS-CoV-2? Well, SARS-CoV-2 is actually of zoonotic origin. What does that mean? That means that it comes from animals. And we're fairly certain now that it was bats. And also we're fairly certain that this occurred in the wet markets in China. Now, what's different between a market and a wet market? In the wet markets in China, the animals that are brought in, many of them are actually alive, which means they can, if they happen to have viruses, they can pass them on. And because they're in close quarters with humans, they can pass them on to humans. And that's what we felt was the transmission point. So the bats gave their coronavirus, which had mutated and changed and was very novel to humans, and they gave it to humans. Now, when it's in the human population, or reservoir, sometimes we call it, there's direct transmission and there's indirect transmission from person to person. The direct transmission is stuff we pretty much know about. People can sneeze it or they can cough it out. Now, if it's large droplets, then they call it droplets, but you can actually have someone cough on you and you can take those droplets in directly. Or they can be much smaller droplets and they can be tiny enough that they can aerosol. They can float around for about 3 hours. And of course, you could be walking along and you could pick these up as you're walking and breathing normally. And then there's indirect transmission. Now, indirect transmission usually involves some form of surface or some form of object. Those are known as fomites. They could be like a cell phone, for example. So if I was in the clinic one day and unfortunately I got hold of COVID-19 and I coughed it while I was using my phone, and then I put my phone down, and as I do pretty much every 4 hours, I lose my phone and I called to my wife, Michelle, and I said, Michelle, where the heck is my phone? And she picked the phone up, then she would actually have the virus on her hand. And if she rubbed her nose, then she would be infected. So that's the indirect transmission, which is actually quite common as well. Direct transmission seems to make a lot of sense, but indirect transmission is also a big way that people pick up the virus from others. So next slide. Thanks, Mile. When we talk about clinical manifestations, because it's a respiratory virus, people do tend to focus in on the respiratory symptoms. So that could be, red eyes, it could be a runny nose, it could be a sore throat, it could be a cough, it could be shortness of breath. And then there's constitutional symptoms which tend to be involved with that, much like influenza. So you can have fever and aches and pains. You can have malaise. Next slide, please, Mile. But it's a bit more complicated than that, actually. Particularly when we're talking about SARS-CoV-2. So what's really important to remember is that the virus SARS-CoV-2 can cause infection anywhere that you can gain access into a tissue. And what it needs is that tissue to have an ACE2 receptor. And that's an angiotensin converting enzyme 2 receptor. So if in fact we have receptors, ACE2 receptors all over the body, infection can occur all over the body. And in fact, that's what makes SARS-CoV-2 and the distribution of symptoms so unusual. So we do have ACE2 receptors in different locations in the body. For example, the heart or the kidneys or the intestines. So if the virus works its way into the blood and works its way down into the heart, it can actually cause infection of the cardiac tissue, the heart tissue, and can give rise to what we call myocarditis, or an infection of the heart tissue, and it can cause dysfunction of the heart. It could be in the coronary arteries, and it could give rise to a clot, which could be a heart attack, or it could go to the kidneys, the glomeruli, the filtration system of our body through those kidneys, through those glomeruli. And if the dysfunction occurs there, then you can go into kidney failure. In the intestines, if you have an infection of the SARS-CoV-2 with the ACE2 receptors in the intestine, you can get diarrhea. And it goes on and on and on. There are a couple of weird and wonderfuls that people talk about. So for example, up closer into your face, when you actually breathe in the virus, if it actually attaches onto 2 of our nerves, our olfactory nerve, which is for smell, or our 7th cranial nerve or our 10th cranial nerve, the facial and the vagus nerve, they can actually cause dysfunction in regard to taste. And that's where those weird symptoms come from. Okay, I hope that's clear. I know that's a bit complicated. Mile, next slide. So let's talk about British Columbia's response to COVID-19. Next slide. Thanks, Mile. So one thing that we know is that public health officials, they really understand the chain of infection, and they understand it really well. The chain of infection describes the necessary elements for an infectious disease to cause infection in a susceptible host. So it's kind of like a clock. So if we start at 12 o'clock, you have to have an infectious agent. And that infectious agent, going clockwise, has to move through a reservoir of people, and then has to exit the reservoir of people, and has to be transmitted to a susceptible person. Now, within the susceptible person, they can have morbidity and mortality, hopefully not. And also there can be a change in that infectious disease, because mutations always occur every time an infectious disease goes into a body and replicates. And so that infectious disease can change, and you can see the clockwise rotation going on again. But the key thing about this is that when you look at the chain of infection, it's divided into 2 halves. It's divided into a lower half, and it's divided into an upper half. Now, the lower half has to do with transmission, and the upper half has to do with what I do now, which is providing medicines and vaccines. So let's talk about the lower half first of all. Next slide, Mile. So I know you've probably heard this a million times, but to prevent transmission, you have to do some neat things like washing your hands. That kills the virus. Respiratory hygiene. Don't cough straight out. Cough into your arm. Don't cough into your hands. Avoid touching your face. Avoid crowds. Disinfectant, 70% alcohol. Physical distancing, staying at least 2 hockey sticks apart or 6 feet apart from people. Wearing masks. And if you are sick, please stay home. Next slide, Mile. So what's the purpose of that from a public health perspective? Well, it's to reduce transmission. It's to reduce as many infected people as possible. So what we're trying to do on the right side of the slide is we're trying to flatten the curve. We're trying to reduce the amount of people who actually get the infection. We're trying to reduce the amount of people who actually get sick. We're trying to reduce the amount of people that can transmit. And we're really trying to reduce the amount of people that will affect our healthcare system, or at least come to our healthcare system, to utilizing our healthcare system. Because we will get to a point where it's not the family physicians, it's not the urgent cares, it's not the ERs, it's not the admissions hospital, probably will be a critical point where we'll exceed the healthcare system. That will be in our intensive care units, and that will be subsequently to not having enough ventilators, because that's where we get with SARS-CoV-2 infection. It's called acute respiratory distress syndrome, and it's a place where you will need to be mechanically ventilated and you will need to have some extra support. And the problem occurs is that when we've used up all our ventilators, the next person that comes in and needs a ventilator won't get one. And that's a serious concern. So that's why we use those transmission reductions to avoid people getting infected and to avoid overwhelming our healthcare system. Next slide. Thanks, Milay. So let's talk about British Columbia's response to COVID-19. Well, multiple things occurred. There was leadership, there was compassion, and there was compliance. And you good folks in British Columbia got some great leadership from the Health Minister, Adrian Dix. Also some great leadership from your Chief Medical Officer, Dr. Bonnie Henry. And I have the pleasure of have met Bonnie. I've known her for a couple decades now. And she's just a really good person, and she's very compassionate. And I think she showed that compassion through the media, compassion of really focusing on those people that were vulnerable, and speaking, quite frankly, about the fact that people were dying because of this SARS-CoV-2 virus. Then it came to you folks, compliance. The residents of British Columbia were really amenable to Minister Dix and Dr. Henry's recommendations, and they were able to institutionalize them. And that's where the success came. Now, those are really good times, and but there's something that is concerning, and that is pandemic fatigue. People do get fatigued by all these different transmission behaviors that you have to go through, and it is challenging. And then there's an economic component to that. So that's where we're really hoping that, we can get a vaccine as soon as possible. But as soon as possible, just right off the top, is months to a year away. Okay, next slide, Milay. So vaccine development, where are we? Okay, folks, so vaccine basics, how do we develop immunity? In order to understand COVID-19 candidate vaccines, it is key to appreciate viral replication in the respiratory cell and the immune system response. Importantly, coronaviruses infect respiratory cells simply to survive. They need to borrow the respiratory cell's cellular machinery in order to reproduce. The immune system, on the other hand, is set up to 1, recognize foreign material like infectious agents, 2, remove or destroy infectious agents, and 3, and probably most importantly, develop a memory for potential or subsequent infections. So if we look at this slide, I know it looks very complicated, but going from the top to the bottom of the slide, the coronavirus attaches to the respiratory cell. It enters the cell by a process called endocytosis. It's broken down by vesicles called lysosomes. The coronavirus genetic material is released and read by the cell's cellular machinery. Proteins are produced. The virus reassembles and leaves the respiratory cell by an exocytotic process in the form of a new virus. Now, once the coronavirus is out of the cell, the immune system takes action. The immune system will recognize the virus by cells called macrophages. The macrophages then ingest the virus and present a portion of the virus on the outer wall. Macrophages now become the antigen-presenting cells because it's presenting antigens. The antigen-presenting cells communicate with T helper cells. This is really the core cell of the immune system, in which 3 main functions occur. 1, to communicate with B lymphocytes, which produce antibodies specific to what's been presented on the antigen-presenting cell. 2, to communicate with cytotoxic T cells, which destroy infected respiratory cells infected with the virus. And 3, to produce a memory B cell and a memory cytotoxic T cell for subsequent infections. Okay, Milay, next slide. So when you talk about COVID-19 candidate vaccines, there are 4 different categories. There's viral, starting from left and going to right. There's nucleic acid vaccines, there's viral vector vaccines, and there's protein-based vaccines. So let's go through each of them and give you an understanding of how each one works. Next slide, Millie. So when we talk about virus vaccines, there's basically 2 different types. There's weakened and inactivated. Let's go to the left side of the slide. So weakened viruses, vaccines, the vaccine is passed through kind of animal or human cells and it causes mutations. Now, these mutations decrease the ability of the viruses to cause disease. These are classically like measles, mumps, and rubella. But when you're given this virus that's weakened in a vaccine, it produces antibodies which will then recognize the real, what we call the live virus, and it will be able to protect you against it. Inactivated, going to the right, inactivated virus vaccines, these are viruses that are rendered uninfectious using chemicals like formaldehyde, which is common in influenza, or heat. So when these are placed into the vaccine, they go into the body, they can't provide disease, but they can provide an immune system response. Once again, the macrophage, antigen-presenting cells, the production of antibodies, the production of cytotoxic T cells, and the memory. Next slide. The next group of vaccines are called nucleic acid vaccines. Now, these are really new. They've never actually been licensed at this point, but they're really unique technology. So what they're doing here is they're taking the messenger RNA of the spike protein of our SARS-CoV-2 virus, and they're actually placing it into the vaccine and giving it to people. Now, there's a couple of caveats here. The first thing is that if you just give RNA to a person, our immune system will see it right away and it'll just chew it up. So you actually have to place that RNA vaccine in this kind of lipid coat, very tiny, a nanolipid coat or particle. And it's placed into the body and can permeate through into the cell. And all that's in there is the messenger RNA. And the messenger RNA is coding for a spike protein, which is the antigen, and then it's released out from the cell, the protein, and then we go through the normal, as we've talked about before, process of our immune system. Our friend, the helper T cell, producing memory B cells and memory cytotoxic T cells. Okay, next slide, Millie. Another type of vaccine, which are becoming very popular, also a very new technology, are the viral vector vaccines. And the viral vector vaccines come in 2 different types. They have a weakened virus, or they have a virus which has been rendered quite inadequate, an adenovirus, a weakened measles or an adenovirus. And what they're doing here is actually placing the genetic material of that spike protein, again, of the COVID-19, actually placing it into the weakened measles or the adenovirus. And then it goes in and it is put into the vaccine, it replicates in viruses, or sorry, it replicates in cells, and then the reproduction process will produce proteins which sit on top of that weakened measles or adenovirus. It's sort of like a bad Netflix movie, actually. So you're putting in genetic material and it mutates or morphs the host cell to have these special types of proteins on the outer coat. Okay, next slide, Millie. So the final vaccine candidate are protein-based vaccines. Now, these actually are fairly traditional. They may not be the oldest vaccines that we have. That's more the virus vaccines, but they are fairly old. The technology of producing the proteins, that's what's been changing over time. So basically what we're saying here is that instead of giving the whole virus, why give the whole virus when you can give a part of it, which actually creates the largest immune system response. So there's 2 different types. The protein subunit viruses, they are actually produced in eggs for influenza or in cell platforms. and the proteins themselves are placed into the vaccine and given to people, and those proteins then produce the immunological response. There's another different type which is quite common. They're called virus-like particles. Pretty cool technology. Basically, you've got a virus, but it doesn't have any genetic material, so it can't cause infection. But on top of that virus that doesn't have any genetic material, they place on the proteins, and then that's passed into the cell. And once again, the immune system recognizes that those virus-like particles, those proteins on the virus-like particles are actually abnormal, and they set off a whole immune system response. Okay, next slide. Now, I hope that wasn't too complicated. It probably was a little bit complicated, but just in summary, essentially, what are you doing with these COVID-19 candidate vaccines? You're giving people through the vaccine something that's going to stimulate the immune system to say, aha, wait a minute, that's not normal. We need to set up a response. We need to produce antibodies. We need to produce these cytotoxic T cells, and we need to produce memory. So when the real thing comes along, the real SARS-CoV-2 virus comes along, we'll recognize it and we'll kill it before it has an opportunity to provide disease. Okay, next slide, Mila. I think the really important thing here, and that's been scaring a lot of people, is that, holy crap, are we ever going fast at this? Usually it takes about 10 years to produce a vaccine, and now we're doing it in about 2 years. But I want just to tell you that it's not that we're shortcutting here at all. We're not shortcutting the phase 1, phase 2, or phase 3 trials. What we're actually doing is stacking them. So that when you're doing a phase 1, you work your way through the phase 1 to your point where you're very comfortable with it, and then you start your phase 2, and then you work your phase 2 through a point where you're very comfortable with it, and then you start your phase 3. But that doesn't mean you don't finish your phase 1 or phase 2 or your phase 3. That just means that the phase 1 and phase 2 may be going on at the same time. The phase 2 and the phase 3 may be going on at the same time, and that's how we're reducing. That's how we're reducing time. And so we're looking at approximately 2 years from start to finish of these vaccines. So next, we'll be going on to preparing for the impact of the upcoming respiratory season. So thanks, Neely, for moving the slides there. So as I mentioned at the top, preparing for the impact of the upcoming respiratory viral season is really been termed twindemic. Maybe that's not quite true, because there's probably more than just influenza and COVID-19 coming. We've got, as always, respiratory syncytial virus. As always, we've got parainfluenza virus. As always, we've got pertussis floating around. But let's just focus on that twindemic. Let's focus on influenza, and let's focus on COVID-19. Next slide, Mila. Thanks very much. I think one of the most important things as well here is that what we're finding, and this is through the National Advisory Committee on Immunization, that the people that are going to be most at risk for developing symptoms and having poor outcomes for COVID-19 and influenza tend to be the same group of people. And that's folks that are 65 years of age and older, particularly people who may have a comorbidity such as pulmonary disease, cardiovascular disease, diabetes, or cancer. And these are us. These are us. These are people that I'm talking to you folks today. You need to be a little bit more careful in regard to protecting yourself against these viruses. Next slide, Mila. When we look at the hard facts, we have influenza on the top, we have COVID-19 on the bottom. Influenza, although we have a vaccine programs in place, and we do a lot of different things to protect ourselves, we still have a fairly significant burden of disease. You've got about approximately 175,000 emergency visits in Canada. We've got about 12,000 hospitalizations due to influenza, and about 3,500 deaths. And what's very notable about this is people 65 years of age and older make up about 90% of those 3,500 deaths. When we look at COVID-19 and the burden of disease in wave 1, we're not 100% sure what the emergency rooms were, because we weren't really watching that closely, but we do know that there was approximately 12,000 hospitalizations and about 9,000 deaths. And of those 9,000 deaths, probably the same as influenza, although we're checking that, about 85 to 90% of those people were people over 65 years of age. Next slide, Mila. So in the face of this twindemic, what can we do? Well, today, what do we have for COVID-19 in regard to a vaccine? Nothing. That's right. We're still working away on it, and hopefully by next fall in 2021, we will have a vaccine in play. So the key is to focus on what we have. And this season, the WHO and NACI are recommending very strongly that people get an influenza vaccine. They're getting an influenza vaccine clearly because we should be protecting ourselves against influenza, but also we're protecting against this kind of confusion that may go on in regard to, do you have influenza or do you have COVID-19? And what do we do if it's COVID-19? If you've got an influenza vaccine, the likelihood of obviously is reduced to getting influenza. So we can focus a little bit more on the fact that you might have COVID-19, and we have to pay quite a bit of attention to that. And the next slide. Thanks, Mila. So when getting a influenza vaccine for people that are over 65 years of age, the National Advisory Committee on Immunization gives some very strong recommendations. So if you go to the left side of the slide, you'll see that there's multiple options for getting an influenza vaccine. But at the individual level, the National Advisory Committee on Immunization would recommend that we would get the high-dose vaccine if available. Now, I can tell you that the good folks there in long-term care there in British Columbia are going to get the high-dose vaccine. I'm not too sure if you're, what's available if you are not in the long-term care. I suspect all the offerings would be available. I think that the key thing here is it's just a much better idea to protect yourself against influenza by getting any of the available vaccines than not getting a vaccine. So that is about it. Next slide there, Mila. I believe that's just the thank you slide. Well, thank you very much for having me. I hope that I was clear. I hope that I didn't confuse by a lot of maybe virus, vaccine, pathophysiology, but I hope it really helps you to really get to the bottom line. We've got some pretty serious viruses floating around coming up in the fourth quarter of 2020. And we need to do our best to protect ourselves. And that protection will be through transmission reduction, and that will be due to vaccinating. Maybe you can hear my dog barking in the background there. So I think he's telling me it's time to stop. So very good. Thanks very much for having me. And we have a Q&A next.
Thank you very much, Dion, for that comprehensive overview. And we'd be happy to answer any questions at this time.